So every time I say kidney, let me move you guys to my camera. So every time I say kidney, watch how I do a kidney. This is a functional kidney. You're going to do a nephron. Glomerulus, proximal convoluted tubule, loop, thick ascending limb, distal convoluted tubule, collecting tubule. And what makes this so unpleasant is it isn't a single organ, is it? Every one of those has its own quite unique function, and you've got to know them all. So it turns out the kidney's kind of 5 organs. So when I say what's a cast is anything that goes from a liquid to a solid state, taking the shape of the structure that it's in. So that could be cement to make all those little lawn gnomes, right? Anything that goes from liquid to solid state. Okay, so what's going to happen in the kidney? Well, so that's the first thing is, what is a cast? It has no specificity other than liquid to solid taking the shape. The second thing is you're going to say, so what's actually going from liquid to solid state? And it's an inherent part of all proteins that if you let a protein be still and it is in a high enough concentration, it will go and form a gel. So that's an inherent physical-chemical property of proteins. That's why it's called Jell-O. They took cows' and horses' hooves and ground them up and cleansed them up so it was pure protein, added some color so it was pretty and a bit of flavor, and you dissolve it into water, heat is good, and then what do you make it do? It sits still. That's why it's called Jell-O. It's a brilliant name. So it turns out that in the kidney secretes a protein called tam-horsefol. So this is one of those really weird names you just got to know. No one knows what it does. Lots of arguments. It's antibacterial, but no one knows for sure. Now remember, I've got to see the cast in the urine. So by definition, where must the cast form? It's got to form in the distal tubule, doesn't it? Because otherwise, how would it get past the loop? So that's why when Nathan said glomerular, I went, okay, not only is it not glomerular, it's tubular, but it sure as heck can't be proximal because it wouldn't get past the skinny bit. Okay? But now, if you ever get a chance to go to the Midwest, which has the worst food in the world, but one of the things they do with their terrible food is they make Jell-O and they put canned fruit in it. Now, I got to say, in all fairness, if you do orange Jell-O and put those tinned mandarin orange slices in it, okay, those are pretty good. But the point being that when you mix in the canned fruit and it forms a gel, guess what you find in the middle of that gel? The fruit is suspended in it. So you can appreciate when we talk about what kind of casts we have, do you think we're going to see lots of casts that are just the tam-horsefol protein? Yes, absolutely we are. It's common as dirt. So when we say anytime we have stasis, proteins will undergo physical chemical property to form a gel. When you restart the urine flow, you get a acellular cast. So the commonest acellular cast is a hyaline cast. And what does that mean? That means they slowed down urine production for a bit. Well, that's really common. You know, we come and go. Life is biology. So that means absolutely nothing. So if I put on my ski jacket in a hot, humid Florida day and I went for a 3-mile run, would I have hyaline casts in my urine sediment at the end of it? Oh, for sure I would. Absolutely for sure I would. Okay? The next type of cast that you're going to pay attention to, and remember what the definition of a cast is: 2 parallel sides and 1 right-angled end. How permanent do you think that cast is? Do you think they're easy come, easy go? Yes. So what's the worst specimen to look at the sediment? First morning void. It's been sitting in the friggin' bladder all night. Any cast is dissolved. So if you want a good urine sediment, and that's always about casts, what are you always going to do? Fresh, clean catch, I'm down to the lab. Hey, could you help me make a sediment for this and look at it? Because they're all gone in 20 minutes. Okay, because it's just the gel. Gel comes and goes. It's a physical chemical state. But now all of a sudden we can talk about, what do we talk about cells? There's an intermediate step called granular. And what granular means is whatever was in the cell has broken down and you don't know, it's debris. So what does that mean? Non-reassuring. I don't know what it means. Could be broken down cells. So go get a new fresh one, try again. Just don't know. Okay? And a good example of this is going to be our muddy brown. I'm always amused when people tell me the muddy brown casts are diagnostic of ATN. No, by definition, they're not. By definition, they're degenerate casts. What I want is renal tubular cell cast. Now, that would be helpful. But it's not nothing. And in the right clinical setting, it does have blood staining and a certain color, and it's helpful. Okay? But the glory of casts is going to be cellular casts. Because the only way I can get cells into the cast is it had to be in the tubule. It is the equivalent of a biopsy. Man, there aren't many tests that let you look in an organ. That's special. So that tells us then there are 3 casts that we really care about. The first is going to be a red blood cell. So give me a pathology that puts a red blood cell into the tubular lumen.
Glomerulonephritis.
Okay, but what's the physical property that puts the red blood cell? So here's my little red blood cell here. What puts my little red blood cells here?
Lack of barrier protection in the glomerulus.
Okay, describe that to me.
You get breakdown of the podocyte foot processes, and you get bigger spaces, and you get red blood cells pouring in.
Tell me about what kind of inflammation is it in glomerulonephritis, Alex?
It's a
well, why don't you tell me? So there's 3 causes of glomerulonephritis. What are they? So when I say glomerulonephritis, what are the 3 pathophysiologies of it?
Isn't one of them a type 3 hypersensitivity?
Good. So we're going to call that immune complex. Agreed? Okay. Help them out, everyone. That's a pass right there. That was a splendid, excellent answer, and I'm delighted by it. So for the gold points, give me a couple others.
Good, Pastor.
Okay, so this is now in pathophysiologic term going to be anti-glomerular basement membrane, right? So that's going to be our classic type 2. And the next one?
Infection?
No, there's no infections that sit tight. It's going to be anti-neutrophil cytoplasm, which is a mouthful, so let's just shorten it, shall we? So it's going to be a type 2 as well, isn't it? Okay, everyone happy with that idea? Okay, so walk me through when my immune complex, antigen antibodies bound together and filtered into the glomerulus. How do I get to glomerulonephritis? And no, you can't invoke angels.
It causes an immune response, and
it certainly does, but that's the angel argument. Okay, put this in your friggin' heads. This is forever, in every situation, doesn't matter what, doesn't matter when. This is a fundamental pathophysiologic part of medicine, okay? Immune complexes activate complement. Immune complexes activate complement. And the second I get C3A and C5A, we're all the way back to what kind of inflammation? Yeah, right. They're chemokines. So that's going to activate inflammation. And what kind of inflammation is it going to be? Day 3 peak is neutrophils. Day 7 to 10 is peak monocytes. Period. So when I say glomerulonephritis, what kind of inflammation is it?
Complement mediated?
It's innate. And what's the cell that's the key of innate?
Neutrophils.
And what do neutrophils carry in their primary and secondary granules?
Myeloperoxidase.
Yes, for killing bacteria, but what else do they carry? What's pus? Oh,
Wait.
they carry proteases out the wazoo. And so when you say to yourself, isn't this great how many pictures we have that you just don't really have in your mind? So when I say neutrophil, right, and you think about this cell like this, it's actually got 4 granules, but we care at your level, we care about 2 of them. So it's got primary granules and secondary granules. So we always talk about the 2 big ones, right? We always talk about myeloperoxidase, which gives pus its yellow-green color, and we always talk about NADPH. NADPH oxidase, because that's going to be our killing enzyme, right? Yeah, but in addition to that, they have huge amounts of proteases, acid proteases. And so when you think of a neutrophil, you not only think of it as killing inside, but what do they always do? They always explode out. And every time you think of a neutrophil, you think of it as inside the neutrophil and then bluey. And that bluey is going to give you 2 really important clinical considerations. The first is going to be netosis. It blows that DNA everywhere, and that DNA forms the matrix for all the enzymes and all the cytokines and organizes the signaling. As well, it's really sticky, and it traps all the bacteria right where all the killing enzymes are. But the second is it's going to get all those proteases for pus. So you never say neutrophil that you don't think of this surrounding liquefactive necrosis from all of these proteases. So Alex, here's what you were missing in your mental picture. Is it actually a physical hole? Yes. Oh, yes. Oh, yes. If you were going to come down, if you were going to look at this end on, you know what it would look like? It would look like this. You'd see all these raggedy holes in it. Because it's why? It's being literally dissolved by the proteases of the neutrophil and the macrophages. God made an incarnate world. Everything in medicine requires a physical chemical explanation. Red cells don't magically fly across membranes. They're 7 friggin' microns, Alex. How do you get 7 microns? I guess there's got to be a hole. And those holes are so destructive that these red cells, actually, if you get a lot of experience, you recognize these aren't normal looking. So a really good tech can tell you without a cast, I've got dysmorphic red cells because they've been damaged going through that environment and those holes, and it damages their membranes. They don't look right. So what's the only way I can get a red cell in a tubule? I got to have a hole. I've got to have a hole, right? And I get a hole how? By digesting a hole. And I digest the hole through how? I've got to have inflammation, acute inflammation. Happy with that? So when I say a red cell cast, it is pathognomonic of glomerulonephritis. No other way to get a red cell in there. Agreed? So walk me through this. So if I've got a physical hole in my glomerulus, do I have to have proteinuria? Doesn't the protein just go pouring through?
The charge keeps the protein from going
There's
through.
a hole. So does there have to be proteinuria? Yes. That's what a good pathophys picture does for you. I don't know, but there's got to be. It's got a freaking hole. How could the proteins not go through? They do. They're just not at nephrotic levels. So when you take a look at nephrotic, that's more than 3.5 grams, or with little kids, it's per kilogram. But when you take a look at your glomerulonephritis, they're 2 to 3.5. So if you can't find a red cell cast, but you have red cells, and you've got 2 to 3 plus proteins, do you have glomerulonephritis? Yes. How else did the proteins get there, right? Happy with that whole idea? Isn't that crazy how you get a good picture in your head, suddenly you don't have to remember as much? Okay, so that's how we get a red cell cast. How do we get a white blood cell cast? And by white blood cell, we mean neutrophil. How do we get a white blood cell there?
Interstitial nephritis.
Go ahead, walk me through the molecular.
That's all I got.
Okay, that's a great answer. Now, and I'll give you attaboy for that. Anyone want to walk me through? I only want one word. All you need is a PAMP, right? All you need is a friggin' PAMP. Watch. If I put a bunch of little gram-negative bugs in there, do they create a signal? They sure do. What signal do they create? 3 things. Give me 3.
IL-1, IL-6, TNF.
Well, that's not the bug.
No.
I want a PAMP. So what organism does that have to be?
Negative. Gram-negative.
Help her out. No, urinary tract infections are all E. coli until proven otherwise. So what organism is it? E. coli. 90% of urinary tract infections are E. coli. In medicine, practical science says 90% is all, 10% is none until you prove it's otherwise. So what organism is that, Melissa?
E. coli.
Yeah, sure it is, right? Okay, so now we know it's a gram-neg. So what part of a gram-neg is so intrinsic to its nature you can't mutate it?
All right. The thing that causes the toxic shock.
LPS, nice. And oh, by the way, anybody that doesn't accept that as a complete answer for LPS is a jerk. That's a complete perfect answer. Okay, what else? What makes it a gram-negative?
Oh, the cell wall, the structure of the cell wall.
Good. So what in the cell wall makes you a gram-negative?
In peptidoglycan.
Nice. So that's not the signal. That's going to be a signal for gram-positives, right? Because they're 90% peptidoglycans. So not that. But what's outside that thin peptidoglycan layer of gram-negatives?
Pores.
A membrane. So they got to have pores. So porons is a really good one. And do they all have flagella? Yeah, they're motile. So if you said to me, thinking about a gram-negative, those would be 3 great PAMPs, right? And now we can go to Melissa's PAMPs to pattern recognition receptors, to resident macrophages and mast cells. Now you can do your cytokines, 1, 6, TNF, and from our mast cell degranulation, histamine and bradykinin and about 80 others. Vasodilation to capture a neutrophil. Circulating to marginal pool. Slow rolling, selectins to addressins. Adhesion, ICAM2,
Cytokines.
integrins. And then they diapedese through the wall and migrate up the cytokine gradient. Okay, well, when they get to this epithelial cell, right? So here's my epithelial cell here, and then this is my urine here, right? So he's on the outside looking in. So here's my macrophage here. Does he just go through those epithelial cells and jump? Yes, of course he does. He has to. Wherever he goes, he's just going to follow the signal till he finds it and phagocytoses and kills it and then erupts extracellularly. Absolutely. So when you go to pneumonia, do you find neutrophils in the pus? Yeah, that's why it's pus. Clearly, they jumped across that epithelial cell. So when they come to the tubular cell, do they just jump? They sure do. And so now all of a sudden you can appreciate, now I've got my neutrophils. There go all my neutrophils into there, right? There go all my neutrophils. So guess what? I can find them in the cast. Therefore, the only way I could find a neutrophil in the lumen of the distal convoluted tubule is there was a PAMP. Therefore, there was something making a PAMP. Therefore, it was going to be E. coli till proven otherwise. So when I say white cell cast, it is pathognomonic of pyelonephritis.
Can you get white blood cell casts from interstitial nephritis caused by like NSAIDs or a medication side effect?
Walk me through it. Okay, so walk me through it.
I don't know if I can. I just know that you
through. Most of medicine you don't know, but if you have really good principles, you can bet.
Well, so if you're talking about, my guess would be that they cause a DAMP in the same area, and then you get white blood cells because it's the same pathway as a PAMP.
Right, but remember, when we talk about the drug damages, there's two different patterns. There's allergic and there's toxic. So you got to differentiate between those two. So if you're toxic, you're just friggin' killing tubular, like gentamicin. You're just friggin' killing the tubular cells. So what you're going to see from that is probably granular cell and renal tubular cell casts. And you won't really see the renal tubulars because it's not acute enough. They sit there and break down. So you're mostly going to see granular casts. But what if you're one of these hypersensitivity allergic ones? Yeah, well, that's mostly interstitial. So it wouldn't surprise me to see a few scattered granulars. Really lucky if you get eosinophils. Less than 10% of them do, but if you did, that would be wonderful. But most of the time, all you're following is a rising creatinine, and it's in temporal relationship with the start of the drug. So every time you see people talking about, well, eosinophilia, you go, yeah, that was a lucky day. Most of the time, you're not going to see that. You're going to have to do a clinical correlation. I started the drug. 2 weeks later, I saw the creatinine rising. I stopped the drug. 4 weeks later, I went back to normal. That's what most of it is. So they're very hard questions. Even though they're really common, very hard to write a good question on that, isn't it? So that's why you think of them as eosinophils, because it gives me a question that's fair, but it's not the right way to think about it. It's about, I started the drug and it didn't go well. Okay, so that's that. And then the last one is when I talk about renal tubular cells. And that's going to be in two different ones, right? If it's acute, I guess they fell off because they're necrotic. So that's going to be acute tubular necrosis. Most of the time, they're muddy browns because it's slow urine flow. But the other place you're going to see it is in transplants. When they start rejecting the tubules, obviously they fall off. So those are the two situations for cellular. What do you think? Pretty good, huh? Come on, Julia. That was really pretty good. I was watching. You were going, well, this makes perfect sense. I'll never, ever forget it. And damn it, I'm going to go buy some orange Jell-O and I'm going to get those tinned slices of man. I'm going to just do it. You can do that when I die. You can say, you know what, in honor of Dr. T, I'm going to do a Jell-O mold with orange slices. Okay, so everyone happy with casts? Really a good story, isn't it? And isn't everything about having a good structure and a good pathophys process, and then walk me through the story of it? And tell me the truth. Aren't you way better on your glomerulonephritis pathology now? The second you know there's only 3. Okay, everyone happy? Okay, so this was one of the coolest questions I ever heard on a STEP exam. I mean, it's shameless pandering to exams, but I have to write a lot of questions, so I have a lot of respect for a good question. They actually showed electron microscopy and said, so what would an immune complex look like? Oh, I just thought that was the most genius question in the world, because all you guys memorize words and don't ever say, what would it actually be? Because there aren't angels. And you know what that looks like? This is the word you use to describe them. It's a lattice. So when you say immune complexes, it's actually a physical structure you can see under electron microscopy. It's just a mesh of all these stringy, gooey things that stick together, and then they filter into this mesh, and then they activate complement, and then we're off to inflammation. So when you say immune complex, you can form a picture in your mind. Okay, well, that was a pretty fun start. Thank you for giving me that pleasure. All right, here's your question. It's the only question we're going to have time for today. Okay, what do we think? Age?
Greater than 65.
So cancer degenerative, right? Okay, gender?
Male.
Male plus 1 atherosclerosis. We don't know where it's going to go yet, but we've set up that prevalence pattern. Time frame? Weeks. Well, I don't know what organ system I'm in, so I'm just going to say this, not acute. I mean, we might end up in liver and then that's awkward, but right now I'm sort of going, okay, it's not that fast. Okay. So then we're going to say, what's our chief complaint?
Altered mental status?
Nice. So anytime I write a chief complaint, what do you know is going to follow? Right? That's the whole point of a chief complaint is you got a differential. So every time you're doing with this, and this works as well for coma, the difference being in coma, you've got to do the 4 drugs to what can't you miss right now. That's the only difference in coma. Okay, so when we say what's the differential, every time you say it, you're going to say this, primary, secondary. Primary means intracranial, which means you're going to do a CT scan. Does CT scan rule out every important primary? Can you say negative, done, not primary? Is it that good? Absolutely, it's that good. It's fantastic. It is fan-friggin-tastic. Remember, Melissa, we're not looking for perfection.
It doesn't rule out acute stroke.
Wow. Okay, let's back up a step.
You gotta get a CTA for that.
Okay, let's back up a step. Someone comes in and goes, gee, there, look at Dr. T came and his face is drooping, his hand drooped, leg's pretty good. What are you going to pencil in?
Well, a CT first.
Yeah. And if it's negative, what are you going to do?
MRI or CTA with contrast.
When are you going to do that MRI?
Well, it depends where you are.
Yeah. Do you need it to know what to do next?
No.
Because what decision are you trying to make, Alex?
TPA versus not.
Right. Right. So what kind of plaque are we dealing with?
Right. But that's for obvious acute stroke. What if it's not obvious?
Well, you don't build
they
your
had stroke. They had
processes
stroke
around
symptoms, and then they went away. Is it going to come back?
Yeah. So what are you talking about now? Are you talking about stroke?
Well, possible TIA versus possible CVA.
You're talking about TIA. So what's the difference between a TIA and a stroke?
TIA you can't see on the imaging.
Right.
They recuperate within 24 hours usually.
Right.
Unless you had a small stroke.
What you're looking for is necrosis.
Unless you had a small stroke that isn't visible on CT but will become invisible on MRI.
Okay. So what is all for learning basic rhythms? What is all?
90%.
Right. So of course you're right. And if you worried about every goddamn exception to the rule, you'd be a really crappy doctor. That's why that's why I went through medicine for 40 years like this, Alex. Because lawyers are watching us and they're all Monday morning quarterbacks and they always say bad outcome equals negligence. And there wasn't a month of my life that my 90% rule didn't screw me over. And that's what you just got to live with. And medicine has very clear aphorisms for this reason. When you hear hoofbeats, think of
Horses.
Not zebras.
Unless you're at the zoo.
Common things are
Common.
right. So when we're building your brain right here, we're building the normal 90%. So when you say to me, wow, Dr. T came, boy, face drooped, hand, it turned out to be a rare kind of cockle thing. Apparently he went to Iraq and ate sheep's liver. And you know what you'd say? Huh. Whereas you came and said, yeah, poor bastard got a big thrombus in his carotid. You got to understand ahs versus wows. But what we build into our brain is the ahs So we recognize what a proper, who would have thought? Nothing drove me crazier when I was running my pathology course. Nothing drove me crazier than some specialists coming and go, so I had this interesting case. Big sheepsook, you're out of there. We don't do interesting cases in medical school. We build normal ways of thinking about crap, okay? So of course you're right. But that's not, you got to know it's rare because you got to know it's common first. So is a CT pretty friggin' good? What would make you do an MRI the next day, Alex?
Resolution of symptoms?
Clinical course or prevalences. You go looking for zebras when it doesn't behave the way you think it should. So I've got my right side gone, and then I get a left-sided symptom. Okay, well, that doesn't fit with my MCA pattern. That's different. So if clinical course doesn't go right or the prevalences are wrong, well, it's Julia. How the hell could Julia stroke? That just doesn't feel right in any way, shape, or form, right? So if Julia stroked, what would you think?
Something else, quite often.
Yeah, something else
going on.
It's got to be something else, right? Maybe she's got undiagnosed lupus and it's a lupus vasculitis. Maybe she's got fibromuscular dysplasia. Wow. Man, I don't feel good about this. I'm good enough. I know clinically if my CT is negative, she's not at risk tonight. So that's fine, right? So think about this. Let's just do a practical application of this. Supposing I present to you with crushing chest pain, and you come in and you see that I've got ST depression and my troponins are up a little bit. What risk group am I in? Am I in the unstable angina group or the STEMI group?
You're unstable angina currently.
No, but I got troponins positive.
Oh, okay. Then you're in the STEMI group.
Is he right, Nathan?
Well, ST depression, so I'm looking for like ST elevation on the opposite lead too. So there's that possibility.
Yeah.
So I'm not going to rule out.
All ischemic subendocardial, not transmural. So there's nothing going to make it ST elevation. It's ST depression and a bump in troponins. What risk group am I in?
High.
Julia?
So hold on. So you're asking if it's NSTEMI or STEMI right now?
I'm saying it's NSTEMI.
Okay. Clarifying.
Because it's got ST depression and up troponins. That's the definition, right?
Yeah. So I would also say you're in a high risk group.
Wow, everyone's wrong so far. Melissa, what do you think?
Well, after that,
Say
I'm
hi.
in a high risk group.
Yeah. So the answer is it depends. No, the answer is it depends. And what does it depend on? What's the magic phrase? Prevalences. So if it's someone that's had MIs before, they're friggin' high risk. If they're old, that's really high risk. You can go through, they actually have charts you can go through and check off the risk profile. So if it was a young athlete and it was a one-off and they had a little bump, they're a low risk person and you treat them as unstable angina. If it was an old geezer, had atherosclerosis out the wazoo, had stroked, and this was his third MI, man, you're treating him like he's STEMI. So the answer is medicine is rarely yes or no. Medicine is always, it depends. Is it behaving as I think it should? And what are my prevalences? It's always that. That's what we mean by clinical judgment. So how do you handle an NSTEMI? It depends.
It depends.
I don't know. You have to tell me how risky this patient looks. And so that would be my discussion with you on primary versus secondary having a CT. If you told me it was Julia, you're right, man. I don't feel good about that. If I told you it was me and I was a smoker and I'd had an MI in the past and I was a little bit diabetic, would you even blink? Right? So you're always in your mind are using your prevalences and behavior. Is this a rule-in test or a rule-out test? So I was just writing some multiple choice questions on shortness of breath after surgery, pulmonary embolism. Okay, so think about this, another really good example of the same problem. Supposing I had a nephrectomy for renal cell carcinoma, and you're called to see me 3 days later because I've had sudden onset shortness of breath. What would you do next?
Anticoagulation.
Have you got a
Yeah.
diagnosis?
You're assuming PE.
Why would you assume that?
That was the answer on my practice problem.
Well, that's incorrect. Whoever wrote that.
Then you would do CTA to check for PE.
What do you think, Melissa?
Well, either a CTA or you need to do a Doppler of the lower extremities and look to see if they also have a DVT or something like
This
that.
is inpatient post-op.
Oh,
Or
inpatient.
in fact, a
post-op.
VQ scan because it's kidney.
Wow.
The D-dimer.
Julia?
You just do a chest X-ray
Okay, Nathan?
first.
I'm sorry. Well, could you repeat the scenario,
I'm
please?
I'm a 65-year-old, 3 days post-op radical nephrectomy for renal cell carcinoma that's 3.2 centimeters low stage.
And you have
And what are you?
And I've suddenly developed sudden onset shortness of breath. What do you do next? It depends. It depends. Am I high risk or low risk?
You're high risk
You're high
Why?
risk. Because you're
because you just had surgery.
and
That's
cancer.
one.
3 days later,
Cancer.
you're short of breath.
2,
You're over 65.
Old.
3.
3 days
You're
post-op.
short of breath. Your physical exam.
Well, by definition, we're starting at short of breath.
Okay.
You're 3 days post-op.
Recent surgery, yeah. Okay, so that's called the modified Wells criteria.
So we're at 4 then.
Right.
4.
But
so
what are you going to do next? Okay, so I'm high risk. Great. What do you do next?
anticoagulate if it's after.
No, you have to prove the embolus. So
Oh.
what test do we do in modern American hospitals?
CTA.
Doppler
CTA.
ultrasound.
Okay. So the answer is first you decide risk and then you decide test. So Julia is quite correct. High risk goes to CT angiogram.
Unless their creatinine's too high and you go PQ.
We'll talk about that in a sec. Okay. If I was 30 and I was post hernia repair, now what would you do?
Dimer?
Yes. Rule in, rule out. High risk peoples, you do a rule in test. You go looking at the pulmonary artery. Low risk people, it's a rule out test. D-dimer, if it's normal, you're good. If it's not normal, that's awkward. Okay? So with every patient, what do we always start with? Age, gender, time frame, and prevalence drives all clinical decisions. Everyone happy with this discussion? It's just a way of thinking all of a sudden, right? When I said to you, predictive value positive is proportional sensitivity, that's going to drive everything on the presentation side, diagnosis of medicine. No kidding, right? It just drives everything. That's why doctors will never be replaced by machines, because you've got to enter the data right on the prevalences, and that's judgment. Okay, so now we've got Julie was absolutely right. She's a mile ahead on her CTA, and she's got a nice major PE. What do you do next for the gold star, Julia? Go for it.
Anticoagulate.
That's tragic. Next, anyone got a better answer?
Remove it.
And good, Julia. How do you decide?
Well, if it's a major.
This is better. So the answer is it depends, right? It depends on what? What does it depend on?
The size of it.
Hemodynamic stability.
Yes, Nathan. It depends on whether it's causing cardiac output shock. So what's the definition of shock, Nathan? Help him out.
Decreased perfusion.
Well, that's what it is, but how do we actually diagnose it? What's the diagnostic criteria?
Closest to the
90.
tissue.
What's the 90 over 60 for blood pressure?
Right. Systolic less than 90. Okay. So when Julia, who's now days ahead of everyone with her CT angio, sees that it's positive, what does she want to know next?
Hemodynamic.
Blood pressure. Yeah, you want to know blood pressure, right? And if blood pressure is less than 90, that's Nathan's hemodynamic compromise. Now you're going to do revascularization. So what are the two ways you revascularize?
Thrombectomy was mentioned, and also you can do fibrinolysis.
Right, that's right. It depends on your technical capabilities, doesn't it? Okay, you either pull the clot or you dissolve the clot. Okay, And if it is normal blood pressure, what do you do? Now you can say it, Julie.
Thrombolysis.
No, the blood pressure is normal. So shortness of breath, positive embolus on CTA, blood pressure normal.
Yeah, would you get fibrinolytics?
Anticoagulation.
You just
Oh,
anticoagulate. No,
Yeah.
that's all right. I mean, it's not. I recognize that you were in a different place. Yeah, you anticoagulate, right? So does anticoagulation treat the clot they've got? Does it treat the embolus? Well, WTF? You just like leaving it there? Seriously?
It'll dissolve eventually.
Yeah, because the body's fibrinolytic systems are fantastic. You only need to buy the body 2 to 3 hours time, and it'll start dissolving it 2 to 3 days time. A big chunk of it will be gone.
So I have a question.
Yeah.
So, yeah, you could anticoagulate and that clot will most likely go away, but can't you also just give fibrinolytics and just get it gone immediately? And-
Sure, of course you can. What's the problem with that?
I mean, there's a risk of obviously bleeding. So, and yeah, aneurysms and bleeding.
3% bleed into your head.
Okay.
So yes, of course you're right. All treatments are a risk-benefit assessment, aren't they? That's why you hear the second you go from diagnosis, you go to natural history. You got to know natural history or you don't know whether your treatment's helping or hurting. You've got to know what happens if I do nothing. So they've done lots and lots of studies back in the day. They just don't talk about it with you guys because they did it in my day. But yeah, the answer is if you compare the 3% risk of bleeding into your head versus doing nothing works fine.
Okay.
Nothing wrong with your idea, of course. If you get a really safe thrombolytic, then for sure you'll do that. Because remember, some of those clots are actually going to cause inflammation, fibrosis, and loss of pulmonary vasculature. Right? That's going to be our class 4 pulmonary artery hypertensions is recurrent pulmonary embolism. So it's not like totally free.
Mm-hmm.
It's just a calculation of natural history of which is riskier. Happy with that? Okay, how are you going to anticoagulate?
Heparin, warfarin bridge.
Nice, right? So heparin before warfarin. And why, Nathan?
Because of I think it's, okay, so there are certain things that
Yeah, I've got that
out
molecular
before.
look in my face. You were going to invoke angels. You went, I don't think I'll try the angel gambit now.
There's initial hypercoagulable state if you start
How?
with warfarin.
Yes, that's
Because-
quite right. Excellent. How?
Because proteins C and S, which are anticoagulative proteins, they degrade first.
Yeah, they have about the same half-life as 7. They both are around about 6. So you never know which one's going to go first. So you buy the 2 to 3 days to transition till all the factors are down and they're clearly anticoagulated. Okay, everyone happy with that? So that's what's really fun about doing medicine is to sit and talk about ideas and say, do I have it right in my head? So when I say shortness of breath, PE, first of all, what test? It depends. High risk, angio, low risk, rule out D-dimer. When you've got a positive clot, what's next? Depends. If they're in shock, it's worth the risk of revascularizing. If they're not, let it sit there. We'll just prevent more from forming. Everyone happy with that? Okay, so when we come to mental changes, and I say to you, primary, is CT good enough? Alex is going to say, yeah, usually. It's good enough for this discussion. If it's Julia, it's not good enough. If it's you, it's fine. Right? Because it just depends on prevalences. Good. Okay, so what are you going to do if it's negative? But there's clearly mental changes.
Get a UA?
Okay, so this is just this was taught to me by a neurologist. I've always loved it. It's worked great all my life. It's one of the very few things I've actually memorized. And I'm just saying, I've always liked this checklist. It's always helped me. So I don't memorize a lot. This is one of the few I did. Okay, and this is what he taught me. Dino. Okay, so let's go through the Dino for the secondary mental changes. It's so common in medicine, I just think it's really helpful. So here's what it stands for. D stands for drugs. So when you said urinalysis, urine drug screen would be a great thing to get right here. Okay, when I say E, this is electrolytes. And there are 2 electrolytes that can give you mental changes. They are?
Glucose.
Sodium.
Sodium, excellent. And tragically, glucose is not an electrolyte, Alexander, but otherwise glucose is going to make it.
Is it calcium?
Yeah, it is. It's got to be pretty high, but there it is. It can do that. Okay. Those are the psychic groans of your little 5-ditty, right? Okay. Endocrine. There are going to be 2 classic endocrines that give me mental changes.
Diabetes.
Exedema coma.
Right. So that's my T4.
SIADH.
Oh, SIADH is going to be hyponatremia.
Okay.
Right? Yeah. Okay. Cortisol, which everyone's speculating is affecting our president right now. So that's perfectly legit, right? Apparently, I've never seen a patient didn't get their cortisol, didn't feel enormously better almost immediately. Okay. N is for nutritional. Okay, so what are my 2 vitamins that can do this?
Thiamine.
Yep.
B12.
Yeah, brilliant. Okay, and then we go into organ failure. Is there any organ that can fail and not give you a metabolic encephalopathy? Not that I know. So congestive heart failure, lung hypoxia, kidney, just do the list of all the organ failures. Okay? And what you're talking about with glucose, Nick, that's going to go into our special category of acute. Okay? So when you say, what are the 3 acutes that are critical in America? What are the 3 that are critical acutes? I'm going to add in B1 here for my alcoholics just because that, I'm from that generation. Okay, so there's your glucose, right? What are my next 2?
PUTI.
Like drugs, like overdose.
Yeah, these are like, so it's Dino plus what can't you afford to miss right now? Death in minutes. Think about the drug use. 70,000 Americans, young adult Americans are dying of this. Opioids, right?
Yeah.
And then the last one, believe it or not, are my diazepams. So you can see what you're going to do, whether you have a lab or not, right? Right. Everyone gets naloxone, everyone gets glucose, everyone gets vitamin B. I can never remember the drug for diazepam. What is it? What reverses diazepam?
Flumazenil.
That's the one, yeah. Okay. Yeah, so Dino plus what can I afford to miss right now? That's a really great list, isn't it? And what I like about it is it tells you what you want to do next. So when we did this old geezer, what we found on his chemistry panel, we found that his sodium was 115.
Very low.
Yeah, low enough to cause mental changes? Absolutely. Okay, so then this becomes our next chief complaint. Hyponatremia is one of the 2 commonest lab abnormalities that you find in the hospital. So it's one of those, you just got to have a differential and you got to have a way of thinking about it, okay? Okay, so the first thing you want to say is it true? Because the pseudo comes when you get an increase in glucose. Anyone tell me how you calculate osmolality based on glucose?
2 for every 100 over 200.
Osmolality equals, if you were going to calculate it off your chem panel, what would it be?
2 times sodium.
Nice.
Then I don't know.
Glucose divided by 18 plus 18,
18
plus B1 divided by 2.8.
2.8.
Okay, so you can appreciate if we define normal osmolality as 285 to 295, the rough rule of thumb is abnormal when it's more than 10 away from that. So you can appreciate anyone that's getting over about 200 glucose, you're going to see osmolar changes in the measurements. Okay, so that's just one thing to think about. So is it true? Then this comes what I think is one of the most confusing algorithms in all of medicine. And that's what we started talking about at the end of yesterday, Alex. So when we talk about how do you think about hyponatremia, you're going to break it into increased volume, euvolemia, and hypovolemia. Now, I'm going to start by keeping it simple, okay? You can add all sorts, like any algorithm, you can really add lots of tricky stuff to it, and it's all true. But like most things, start with the 90% and then build onto it, okay? So when we see increased volume, the question has always been, well, if I've got ADH, doesn't that increase volume? But look what we're going to put on the list of increased volumes. We're going to put congestive heart failure. We're going to put cirrhosis. We're going to put nephrotic syndrome. And we're going to put kidney failure, by which I mean chronic kidney failure. And when I put that, you've got to add some really profound ideas of show me the pictures. Don't just memorize the list, see the list through its pathophysiologic pictures. And for this, you're going to need 2 pictures, okay? The first picture is just for this list alone. When you think about what this list is, this is the list of our Starling's forces. So remember what Starling said. Starling's forces, which of course is the differential diagnosis of edema, doesn't that work out nicely, is going to be, there's my pressure out, so that's my hydrostatic pressure. And then there's my oncotic pressure in. So when you say, give me 2 diseases where my volume is high and gives me increased oncotic pressure, that's going to be congestive heart failure and the hypervolemia of kidney failure. And when you say, what are my 2 diseases where albumin is so low that I lack oncotic pressure to draw it back in, that's going to be my cirrhosis and my nephrotic syndrome. And remember, this is the differential of edema. So it's a very useful way of thinking about this really fundamental thing you learned about a year and a half ago. Okay, everyone happy with that idea? When we come over to the hypovolemias, and again, I'm simplifying for the first version. We can make it as complex as you want later. When we talk about what hypovolemia is, this is going to be our nausea and vomiting and our diarrheas. Yeah, it's just what you thought. You're just pooping and vomiting your brains out. And what that means is then, if no, it's not one of the big 4, it's not a Starling's force abnormality, and then no history of diarrhea vomiting, then this is going to be our SIADH. Okay? Okay, so WTF, here's the problem that I've got.
Can I ask a quick question?
Of course, jump in. Yes, of course.
Where did we talked about diabetes insipidus last week. Where would that fall on this gradient?
Well, it wouldn't, because diabetes insipidus is a deficiency of ADH.
Right, but would it fall? Would you look? I'm just curious. Would it look hypovolemic?
No, it'll be hypernatremic because you can't contain water.
The volume status, I mean.
That's exactly right, Alex. Okay, so let's talk about that. Okay, so that's exactly what we're talking about is, so why are these guys considered hypervolemic and this guy who's absorbing water like crazy is euvolemic? So this is, I think, one of the hardest ideas to wrap your brain around, and we'll finish on this idea, okay? We go all the way back to one of your first weeks in phys, and we said, tell me about total body water. So if I said, tell me about total body water, what would you draw for me? Well, you'd draw this, wouldn't you? Right? That's what you'd draw, right? You'd say, yeah, it's about 60 liters, blah, blah, blah. And I'd say, great, divide that up for me. So you're going to divide it into intracellular, extracellular, right? And so that's like 2/3, 70%, 1/3, 30%, however you want to do that. Good? Now divide up the extracellular fluid. And that's going to divide into interstitial which again is about 70%, and vascular. And when I say now divide up your vascular, you're going to divide it into venous and arterial. And that's about 80%. Everyone happy with that? Does that make really good sense to everyone? There's no point in going on. And Melissa, if I was a biochemist, what would I call interstitial?
Intercellular?
I'd call it
Extracellular.
extracellular matrix, right? So, when you think about how pathologists think, if these are all my cells, when I say interstitial, this is my interstitial space. Okay? Fine. So how are these compartments created? So if I'm telling you these are true standalone compartments, how are they created? How do we create an intracellular compartment with its own physical chemical properties?
Fingers.
Right? When you say intracellular, you're going to have a working ATPase, and it is defined by potassium. Right? Happy with that? And so having that membrane and that working sodium-potassium ATPase, that's what creates an intracellular environment. Okay? When I say extracellular environment, what defines my extracellular environment?
Sodium?
Yeah. Right? So every time I say intracellular, in your mind, you're thinking, yes, I get it. That's my ATPase, potassium. When I say sodium, that's defined and limited by where sodium diffuses to. And when I say vascular, what defines my vascular department? Right? That's defined by my oncotic pressure of proteins and albumin. Okay, where does water go? And the answer is water goes anywhere it wants. Water freely floats in the system. Okay, now let's talk about this in true pathophysiologic terms. If I had something that increased ADH, what would happen to that water? Everywhere. Everywhere, right? So what test would we have to prove that there's too much body water? Well, I know what I'd like to have. I'd like to have an intracellular potassium. I would like to show that I'm diluting intracellular potassium, right? Do I have that test? No. Damn it. Okay. Well, what could I look at next? Do I have a nice interstitial test? Oh, really? There's an interstitial test? How would you collect the interstitial fluid? Nope, I don't have that crap test. So the best test that I've got is a venous sodium. Is it the best test? No, but it's pretty good. So don't expect a lot when you're looking at dilutional effects of water. Don't ask a lot of your sodium, right? Because you're really not measuring the compartment you want, and you're really not measuring the electrolytes you want. But if you could, you know that in your life, you're waiting for an intracellular potassium, aren't you? So when we say intracellular sodium, that's what we mean. Okay, what would happen if I started recovering increased sodium? So let's go to aldosterone. Right? So aldosterone is going to be my ENaC. Right? And so I'm going to recover sodium. Now walk me through what happens. It's going to recover with water, isn't it? But what happens to my patient? It can only stay in the extracellular department, can't it? That's all it can do, agreed? Okay, so what happens when all the pressure goes up here in my intravascular apartment? What happens? And so what do I see in my patient?
Edema.
Edema. But it's probably not going to affect your cells. So you're probably going to be a pretty normally functioning person. So
why does it only stay in the extracellular compartment?
well, how's it going to get in a cell with an ATPase?
Gotcha. The sodium, but the water can't get through either.
So when you say to me,
Sorry,
go ahead, Julia, please.
the water can get through because it's highly concentrated on the outside, so it's just going to follow solute, stay on the outside.
Because our lipid membranes are leaky enough that it will just follow the oncotic gradient. Not the oncotic. It'll just follow the pressure gradient. So it'll just passively diffuse across the membrane from a high concentration to a low, just like that potato thing we did in grade 3. Because the membrane doesn't restrict it. That membrane sure as hell restricts sodium because it's got the ATPase. Right? I mean, the second the ATPase breaks, what's the first thing we see in cell injury?
Swelling.
Yeah, because sodium gets in. Everyone happy with that? Okay, so if you gave me gallons and gallons of water, I would decrease my osmolarity. And would that be true in my cells as well? For sure. So all we're talking about is which cell breaks first. So when you talk about who your patient is, which cell breaks first?
Red blood cells?
Only if you're dripping it right onto them, Nick. Which cell breaks first? The neuron. So when you say what is the first manifestation of hyponatremia, it's going to be mental changes. But that's if you poured water into me, right? But what happens if you poured salt into me? I'd get edema. I'd still be functioning fine, wouldn't I?
So if you're a patient with diabetes insipidus, you would also be euvolemic because it's just an ADH change?
Yeah, until you lost. Yeah, and so that's right. If you have diabetes insipidus, as long as you have access to water, you're normal. As long as you have access to water, right? So they're fine as long as they can drink. If you restrict the water, well, then they just volume deplete because they're losing water. But as long as they got water, they're fine. Okay? So when you come back up here and you take a look at this hypovolemic, euvolemic, hypervolemic, when we say hypervolemic, we don't really mean that, do we? We really mean sodium hypervolemic. Because you notice the ones we put in that is our edema list. So when we say this patient has hyponatremia, let's just finish this up. So if he's got hyponatremia, right? So here's our hyponatremia. Why has he got an increase in his ADH? So this is serum inappropriate ADH syndrome.
Paraneoplastic syndrome?
Yeah, that's right. You would bet the next thing you'd do is you'd do a chest x-ray. So you're going to see this in two really common situations. Post-op and lung cancers are the two common. There's lots and lots of things, but those are your big two. So I don't think I've ever had an exam writer that in her first 25 questions, that wasn't one of the first 25 questions. If you come and write exam questions for me, that'll be one of your first 25. It's just a classic. Everyone happy?
Just a quick question.
Of course.
So if someone has this, like this has been going on for a few weeks.
Yeah.
So
because what's the rhythm of an aggressive cancer, Julia?
Huh?
What is the rhythm of an aggressive cancer? What time frame of symptoms for an aggressive cancer?
Very acute.
Well, sort of
I mean,
in the 8 to 14 week range,
yeah.
right? So that's about right, weeks.
But so I guess I'm a little like, if someone was becoming hyponatremic, I just feel like that would have happened not over the course of a few weeks. That would have been like an acute change.
But remember, he's not going to be remember, okay, that's a perfectly fair question. What is the difference between SIADH post-op and SIDH from a tumor? Right? That's really what your question is.
Yeah.
And that's a really good question. So let's just talk about the two. So if we talk about lung cancer, this is where everyone gets their thinking wrong. They always say, wow, he went so long and then he went downhill so fast. Yeah, because human brains think in linear terms and biology is exponential. So when we take a look at the time that you survive and we talk about doublings of the tumor, this is what everyone forgets. This is log scale. These are all doubling times. So when you say, I want to go through 10 to the 6th, right? 1 million cells is 1 centimeter. To get to 1 million cells, you've typically got to go through 6 to 8 divisions, right? So most of our cancer's life is asymptomatic. And then you start becoming symptomatic here. That's at about 10 to the 9, but these are doublings. And so you die at 10 to the 11th to 10 to the 12th. So when you say, oh, well, I think about cancers in 9 to 14 weeks, yeah, you're talking about this part of the time. Because if you're just doing it in real life, it actually looks like this. And you go, oh, that's so odd. He was doing so well for so long. Yeah, well, you didn't understand doubling times. So this is what's going to be so hard in your cancer carers, right? Everyone's going to do so long until they do really badly. So when you say, gee, that doesn't make sense to me, the answer is sure, because how much ADH is he getting right here? So he might have been acting a little odd, but not enough that he could rally to the situation. It was finally when he started talking to his dead mother that his wife realized it was time to go do something. And that's a problem, right? That asymptomatic phase is the majority of your time in cancer. You don't see the symptomatic phase is right up there as you're getting this really rapid singularity curve. Okay? So that's why that's why the time is odd. It depends on the doubling time. Okay, I'll finish up with this one story. So when I was a young pathologist, and I used to do lots of bone marrows because I came out of a leukemia center, and I called an ER doc. We see a leukoerythroblastic smear, meaning we see nucleated red blood cells and immature white blood cells, and it doesn't make sense to us. You've got something wrong in that patient's bone marrow. And he said to me, well, that makes really good sense. It's this really sick-looking lady, and I don't have any idea what's wrong with her. And he said, so what should I do about your call? I said, oh, well, it's in her marrow. She needs a bone marrow done. And he said, well, do you do that? I said, well, I do that. So I went down to the ER with my little tray, and I did her posterior superior iliac spine, and I sucked it out, and it was gray goo. It wasn't bone marrow at all. It was gray goo. And I looked and went, because she couldn't see me, was like, oh my God, I've never seen this. So I went down to the lab and I smeared it out and just took a look at the smear. And you know what it was? Small cell carcinoma. And I called him back and said, oh, dear Lord, she's full of a small cell. He said, well, she hasn't got a diagnosis. And she died in the ER before we even got her to a hospital bed overnight. So that's what doubling times mean. When they say small cell carcinomas are the fastest growing tumors in adults, that's what that means. She went from asymptomatic to sick over a week and died the next day because she was on this part of her curve. You know what the fastest growing tumor of all tumors is? Small cell's number 2. You know what number 1 is, anyone? It's Burkitt's. And you're not going to see the little kid with the mosquito bite Burkitt's. You're going to see non-endemic Burkitt's, which is an abdominal mass. Those abdominal masses grow over a week. We actually had a little kid in which they had an abdominal mass, and they stuck it was so big they just stuck a little needle and sent it in. I said, well, it looks lymphoid. It looks really sort of like it's mitosing really fast. Do you want me to mark it? They said, wait, we'll call Boston and see what they said. And they said, so we've got this little 10-year-old boy with an abdominal mass, and our pathologist says it's some kind of really active lymphoma. And they said, yeah, well, put him in the ambulance and drive him down. We'll be waiting at the door for him. That's what doubling times mean. So whenever you think about the rhythm of disease and you think about cancer, and I say indolent, aggressive, in your mind, you're doing doubling times, right? So when you say, gee, the symptoms seem so nothing and then they became so prominent, yeah, you just got this part of the curve. Our brains are linear, but nature is exponential.